Hello everyone and welcome to our module on asthma. Asthma is a lung condition in which patients develop reversible bronchoconstriction. The word reversible is important here because reversibility distinguishes asthma from other lung conditions like COPD, where the symptoms are usually not reversible. And when bronchoconstriction occurs, this leads to dyspnea and wheezing, and we'll talk about the symptoms in a minute. Patients who have asthma usually have bronchoconstriction triggered by an allergic stimulus. Asthma is an allergic or hypersensitivity disorder. It's an example of a type 1 hypersensitivity reaction. Asthma is common in children, although it can also be seen in adults. And many patients who have asthma also have other allergic conditions, otherwise known as atopic conditions. So patients with asthma commonly also have rhinitis with runny nose and eczema with skin rashes. In addition, they often come from families where there's a family history of allergic reactions. Patients with asthma have episodic symptoms, so they will often be well for a period of time and then they will be exposed to a trigger, and that will lead to the onset of symptoms. Symptoms can include dyspnea. Wheezing is a classic symptom of asthma. Patients can also develop cough. If symptoms are severe, they can lead to hypoxemia. On physical exam, in addition to wheezing, another classic finding is an increased expiratory phase. So if you listen to the patient when they breathe, the expiratory phase when air is leaving the lungs will be prolonged. That's because of bronchoconstriction, which causes exhalation to take a longer period of time. This is sometimes described as a decreased I to E ratio, meaning the ratio of the time for inspiration compared to expiration is decreased in patients with asthma, and that's because of that prolonged expiratory phase. Reduced peak flow is a classic finding in patients with asthma. This is a peak flow meter. What you do is you blow into it forcefully and it measures the peak airflow. And in patients with asthma, they are often taught to measure their own peak flow because if it begins to fall, that's evidence that an asthma exacerbation may be coming on. Patients with asthma often develop mucus in the lungs, and this can lead to plugging where the airways become obstructed and blood can be shunted around those obstructed airways, leading to hypoxemia. And then finally, death from asthma is uncommon in the modern era, but when it does occur, it can happen because of status asthmaticus. Status asthmaticus basically means persistent asthma symptoms that cannot be relieved, and this is an uncommon but possible cause of death from asthma. The diagnosis of asthma is usually made clinically if patients have typical symptoms, if they have wheezing on physical exam, and especially if they improve with administration of a bronchodilator like albuterol, then usually if all these things are present clinically, we say the patient has asthma. The peak flow can be measured to support the diagnosis of asthma. The peak flow is reduced in patients who are having asthma symptoms, as we talked about before. Pulmonary function tests can also be used to make the diagnosis of asthma. What you see in patients with asthma are typical results for obstructive lung disease, which I talk about in another video. But those results include a reduced FEV1, a reduced FEV1 to FVC ratio, and importantly, the FEV1 has to improve significantly after administration of a bronchodilator like albuterol. The definition of a significant improvement in FEV1 is not standardized, but most people say if the FEV1 goes up by 12 or 15% or so, that's significant, and that indicates asthma. You can see smaller improvements in FEV1 in other disorders like COPD, but these large improvements usually are only seen in patients with asthma. There is a rarely used test for the diagnosis of asthma called a methacholine challenge. This is usually done in people in whom you're not sure they have asthma, you wonder if they might have some other disorder. You can do the methacholine challenge to try and identify whether they have asthma or not. So the methacholine challenge involves administering methacholine, which has a structure very similar to acetylcholine, and therefore it functions as a muscarinic agonist and it causes bronchoconstriction when it's inhaled. And the way you do this test is you administer increasing amounts of nebulized methacholine and you perform spirometry after each dose. And you look for the dose at which the FEV1 starts to fall by 20%. And if the dose that provokes a fall by 20% is 20 micrograms or less, that's a positive test. So people who don't have asthma will be able to tolerate a very high dose of methacholine before they develop bronchoconstriction. People who do have asthma will develop bronchoconstriction at low dosages, and that's how this test works. Some other tests that can be done to support the diagnosis of asthma are shown in this slide. The CBC may show eosinophilia because this is an allergic reaction. The serum IgE levels can also be elevated. That supports the diagnosis of an allergic reaction like asthma. And then finally, pulsus paradoxus is a fall in the systolic blood pressure of more than 10 millimeters with inspiration. This is usually considered a sign of cardiac tamponade, but you should know that the most frequent non-cardiac causes of pulsus paradoxus are asthma and COPD. So the blood pressure in a patient in the midst of an asthma exacerbation can show a fall in systolic blood pressure consistent with a pulsus paradoxus. So now let's talk about some of the drugs used for the treatment of asthma. And the two major types of drugs used for asthma treatment are beta agonists and corticosteroids. Beta agonists activate beta receptors in the lungs and cause bronchodilation. There are short-acting beta agonists, sometimes called SABA. The major drug in this class is albuterol. It can be given by nebulizer or as an inhaler. And then there are long-acting beta agonists, sometimes called LABAs. Major drugs in this class are salmeterol and formoterol. These are usually given as inhalers. And the idea here is to give a drug that has a long-acting beta agonist effect to keep the lungs dilated throughout the day. Side effects of these drugs are rare because they are usually not absorbed systemically. If some of the drug is absorbed systemically, some of the side effects that can occur are tremor and palpitations, and these are from beta agonist effects throughout the body. Corticosteroids are powerful immunosuppressants, and they can be given to patients with asthma in a couple of ways. They can be given as an inhaler. They can also be given as oral drugs or intravenous drugs. Oral and intravenous drugs are usually reserved for patients having severe asthma symptoms. In particular, intravenous drugs are usually used in the hospital. Long-term use of corticosteroids is associated with lots of adverse effects, like effects on cortisol production and glucose and bone biology. But none of these things are usually an issue if corticosteroids are given in an inhaled manner or given as a short course as oral drugs or intravenous drugs. The main problem with corticosteroids when they're used in asthma is that patients inhale them, and this often causes thrush. This is a picture of thrush shown on the screen here. When patients inhale corticosteroids, some of the drug gets on the tongue and the buccal mucosa. This suppresses the immune system and allows candida to grow, and that's what thrush is. It's a candida infection of the mouth. Because thrush is such a problem, there's a couple of things patients are advised to do to prevent thrush from occurring. The first is to rinse after they use a corticosteroid inhaler, and the second is to use a device called a spacer. A spacer is a big hollow chamber that can be filled with the inhaled corticosteroid drug, and then the patient can slowly inhale it into their lungs. And when they take it this way, it's less likely that the drug will get onto their oral mucosa in their mouth. Eicosanoids are cell signaling molecules, and there are three types. There are the leukotrienes, the prostaglandins, and the thromboxanes. And the leukotrienes are major mediators of asthma, so there are two drugs that inhibit the synthesis of leukotrienes from lipids in the cell membrane of cells. The first one is Xyloton, which inhibits the enzyme lipoxygenase. The other one is Montelukast, which directly blocks leukotrienes. And I've listed these drugs on this slide. Leukotriene receptor antagonists, the main one is Montelukast, which goes by the trade name Singulair. This is particularly useful in aspirin-sensitive asthma, and we'll talk about why in a few slides. The other drug that inhibits the eicosanoids is Xyloton. It's an oral drug. It inhibits 5-lipoxygenase, and as we just saw in the last slide, it blocks the conversion of arachidonic acid into leukotrienes. Some other asthma drugs are shown in this slide. Omalizumab is a monoclonal antibody. It's given by subcutaneous injection. What it does is it blocks the ability of IgE to bind to IgE receptors on mast cells and basophils. So when these cells bind less IgE, they are less likely to degranulate when they are exposed to a trigger. Cromolyn can be administered by an inhaler or a nebulizer. It's a drug that inhibits mast cell degranulation, and therefore it blocks the release of intermediates like histamine and leukotrienes. And then finally, theophylline is a bronchodilator. It's very rarely used in asthma. It is sometimes used in COPD, and I talk about this in more detail in the video on COPD. So here's a slide showing how I think about asthma and asthma drugs. The process of developing an asthma exacerbation begins with exposure to an antigen, and it ends with bronchoconstriction. So the first thing you can do to treat asthma is educate patients to avoid exposure to triggers. As we've discussed, omalizumab blocks the ability of IgE to bind to mast cells. Steroids Xyloton and Cromolyn block the degranulation of mast cells so that those cells do not release mediators of asthma like leukotrienes and histamines. And then finally, beta agonists and theophylline are bronchodilators, so they oppose the bronchoconstriction caused by mediators of asthma. And finally, leukotriene receptor antagonists block the ability of leukotrienes to generate their effects. Okay, so those are the drug classes, but now we're going to talk about specifics of how you decide which drugs to use in a particular patient. And to understand this, you have to appreciate that there are two ways we treat asthma. When patients have an acute exacerbation, there are certain drugs we use to relieve bronchoconstriction. And then in patients who have recurrent episodes, we administer long-term chronic therapy to suppress the asthma and to make it less likely that a patient will develop an exacerbation. So let's talk about treating acute exacerbations first. Children or adults with asthma who present with an acute exacerbation of asthma will have the symptoms we talked about before. They'll have shortness of breath, wheezing, cough. They can have chest tightness. They will have a decrease in peak flow from baseline, so children with asthma are taught to measure their peak flow regularly, and if it begins to decline, that's a sign that they may be developing asthma. The diagnosis is clinical, as we talked about before. However, almost always a chest x-ray is obtained, and that's to evaluate for pneumonia or other pulmonary infection that may have triggered the asthma exacerbation. The mainstay of treating asthma is to administer oxygen and administer nebulized albuterol to cause bronchodilation. Beyond this, many people with asthma exacerbations require steroids for a period of time. These can be done intravenously in the hospital or given orally as an outpatient. For example, prednisone 60 milligrams daily as an outpatient, or methylprednisolone 80 milligrams IV every Q hours. These are typical regimens, although there are many others. Some drugs that can be used but are rarely used are ipratropium and IV magnesium sulfate. Ipratropium is a muscarinic antagonist, and it's more commonly used in COPD, but it can rarely be used in acute asthma exacerbations. An intravenous magnesium sulfate also causes bronchodilation, so this can be used in rare cases of asthma exacerbations. And then finally, one thing to know clinically and for your board exams is that an ABG is often done in patients with acute asthma exacerbations. And these patients are hyperventilating to try and get oxygen into their lungs, so their PaCO2 should always be low. Any patient with an asthma exacerbation or a COPD exacerbation, for that matter, should have a low PaCO2. If the PaCO2 is normal or increased, this is very, very bad. This means that that patient is developing respiratory muscle weakness and they are on the verge of respiratory failure. That's often an indication for intubation or non-invasive ventilation or some other significant support of their breathing status, because it is very, very abnormal to have a patient who is short of breath in the midst of an asthma exacerbation with a normal or increased PaCO2. In acute exacerbations of asthma, empiric antibiotics are not recommended. And what I mean by this is we do not give antibiotics to people with asthma exacerbations unless there's definite evidence of infection. And this is an important distinction between treating exacerbations of asthma versus exacerbations of COPD. In another video, I talk about COPD, but when those patients have an exacerbation, we always give antibiotics, no matter what the chest x-ray shows. In contrast, for patients with an asthma exacerbation, antibiotics are only indicated if you have definite evidence of infection, like, for example, an infiltrate seen on chest x-ray. And along those lines, when you administer corticosteroids to people with an asthma exacerbation, their white blood cell count is going to go up and show a left shift, meaning an increase in the number of immature white blood cell forms. This is a normal response to corticosteroid therapy, and it doesn't indicate an infection. So both in real life and in a board question, if a patient with an acute asthma exacerbation is given steroids and a day later has a spike in their white blood cell count, that does not mean they have an infection. That means they're having a normal response to steroid administration. Now I'm going to talk about how to treat asthma with long-term therapy. And the goal of long-term therapy is to suppress asthma symptoms and make it less likely that the patient will develop an asthma exacerbation. And in order to decide on what therapy patients need for the long term, you have to first assess the asthma severity. And the asthma severity is based on the frequency of daytime symptoms and the frequency of nighttime symptoms. And asthma severity ranges from intermittent to severe persistent. So let's talk about intermittent first, which is the mildest form of asthma. Patients with intermittent asthma have daytime symptoms less than or equal to twice per week, and nighttime symptoms less than or equal to twice per month. In addition, if you look at the bottom of the screen, these patients also have no activity limitations and they have normal pulmonary function tests. Patients that meet all these criteria are said to have intermittent asthma, and they need the mildest form of chronic therapy, which is step 1 therapy, which we'll talk about in a minute. The next step up in severity is mild persistent asthma. Patients with mild persistent asthma have either daytime symptoms more than twice per week or nighttime symptoms 3 or 4 times per month. After mild persistent comes moderate persistent asthma. Patients with this condition have daily symptoms, and they have nighttime symptoms at least once per week, but not as often as every night. And then finally, the most severe form is severe persistent. These patients also have daily daytime symptoms, and they have nighttime symptoms almost every day of the week. And the reason you need to know how to identify asthma severity is because it determines chronic therapy. Chronic therapy is treated in a stepwise manner. You administer the appropriate treatment, and then you increase to the next step until the patient's symptoms are controlled. So the first thing to know is that step 1 therapy is a short-acting beta agonist as needed. So these patients take albuterol, and they only use it when they have wheezing. And this is the therapy for all patients with intermittent asthma. Above step 1 is the treatments for all patients who have the various forms of persistent asthma. And they can be treated with things like low-dose inhaled corticosteroids, medium-dose inhaled corticosteroids, long-acting beta agonists, and finally, if they get all the way up to step 6 and their symptoms still aren't controlled, they're administered oral steroids. And in any patients with persistent asthma, you can potentially add these drugs shown at the bottom, like a leukotriene receptor antagonist, xylitol, theophylline, or omalizumab. Treating persistent asthma is complicated. It's not something they're likely to ask you about on step 2 or step 3, but you should know how to identify the patients in the mildest group, those ones that only need a short-acting beta agonist. So I mentioned earlier in this video that aspirin is a trigger for asthma in certain patients. Those patients have what's known as aspirin exacerbated respiratory disease, or AERD. These patients develop asthma, chronic rhinosinusitis, which presents as a runny, stuffy nose, and nasal polyposis, meaning they have polyps in their nasal passages. These patients have chronic asthma and rhinosinusitis symptoms, so they're always complaining of wheezing and runny noses, and they will develop an acute exacerbation anytime if they take aspirin or NSAIDs. This is a special subtype of asthma. These patients all have dysregulation of arachidonic acid metabolism, that slide that I showed you earlier on the eicosanoids. And in particular, what these patients have is overproduction of leukotrienes. And because of this, the hallmark treatment of AERD is a leukotriene receptor antagonist like montelukast or zafirlukast. These drugs block leukotriene receptors and they're very effective for AERD. I'll finish with one slide on chronic cough. Many patients present to their primary care doctors with a complaint of chronic cough, and there's a standard differential, and it's shown on this slide. One of the first things you want to consider is asthma, because asthma can present as a chronic cough. So in any patient with chronic cough, you want to examine them for the presence of wheezes, and you may even consider additional testing for the possibility of asthma. Another common cause of chronic cough is postnasal drip. This is common in patients who have allergic rhinitis. So these patients will have a stuffy nose and then complain of a chronic cough. And the treatment for this condition is usually intranasal glucocorticoids. Gastroesophageal reflux disease, or GERD, you may think of as causing heartburn, but it can also cause wheezing. Some of the gastric contents can get into the lungs, so this can cause wheezing and a chronic cough. These patients will also have a sore throat and hoarseness. They may complain of chronic cough that occurs at night or after meals. All these features suggest GERD as a diagnosis, and the treatment for GERD is usually proton pump inhibitors. And then finally, chronic cough is a classic side effect of ACE inhibitors. About 10% of people who take ACE inhibitors develop a chronic cough. So in any patient with a chronic cough, one of the first things you want to do is examine the medication list. So on your clinical rotations, you will see patients who have chronic cough. Your preceptor will ask you for the differential, and this is the differential shown here on this slide. And that concludes our video on asthma.